Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrics. David, who do we have today as a guest?
Well, John, we have an illustrious guest today, Dr. Zeke Emanuel, Vice Provost and Professor of Medical Ethics and Health Policy at the University of Pennsylvania. He has a long list of honors. Toward the top of the list, John, is that he's a former CareTalk guest. You know, we don't always invite people back, but that's one of the top things.
He's kind of achieved a bunch of other things that I think sit a little bit out of that, but that's just my.
It's just your opinion, John.
Zeke, welcome back. And the topic today: people versus COVID. Who's winning?
Well, it's definitely COVID has the upper hand at the moment. We're in the BA5 surge, and I think that's going up. We're now past 40,000 hospitalizations, which is probably our best marker of how severe it's going on. People who get COVID are experiencing sort of a prolonged flu-like symptoms, which are the worst flu they've ever had, at least by anecdotal report to me. And everyone's expecting to get it. So it's also a real problem. On the other hand, the public health community is like, this is a serious problem, and we've really got to take serious precautions, but no one's listening to them, as far as I can tell.
So
not
Zeke,
the public and not the politicians.
So Zeke, I have like a riddle for you, which is, why isn't the public involved in public health?
Well, the public has to respond. I mean, public health people make recommendations, whether it's wearing masks or avoiding crowds or whatever. And if the public doesn't respond, you're not going to promote the public health. And I think that turns out to be a huge, huge problem.
But Zeke, I talked to my 88-year-old mother. She says, look, I'm vaccinated, I'm boosted. I'm a cancer survivor, but my friends aren't getting sick. Where I want to live my life. I'm a nurse, so I get the fact that I should be scared, but I'm not. I want to go out and experience my life. I was depressed. I'm just playing that out. Someone who'd be a prime target for a dangerous case of COVID, and it is definitely a negotiation as to how much she's going to adjust her life.
And I think she's right there with most Americans. Is we've done this for 2.5 years, 30 months. That's it. Mas, I'm done. And so we want those social activities part of life back. We want to be able to go to indoor dining, social events, not have to wear masks, travel. Not unreasonable. So I think that's where we're at.
Well, you're the public health expert. You should be the national COVID expert. So what can we do given that weird imbalance between what the Eric Topol's and Bob Wachters, the doctors who are sort of ringing the alarm around some of this, and the rest of us? How do we bridge that?
I think it goes back to what David said, which is the word public is in public health. And unless you carry along the public, you are not going to have any response to public health. And we can't, it's like politicians know you can only go ahead of the public so far. If you lose the public, you're not going to be a politician for very long. And similarly for public health people. What does that mean? Okay. It means, number one, accepting that COVID is endemic. And as the public has pointed out, we're living with it. We're not going to conquer it. We're not going to see it in the rearview mirror, as it were. We're going to have to live with it. Second, that also means, I think, very interestingly, we are going to live with increased risk of getting a serious infection, increased risk of hospitalization, increased risk of death, but also importantly, increased risk of, I think something I certainly fear, I think the public fears probably a little less, is long COVID and disability. But the public's willing to accept that for the other things, the social life, school being normal, indoor dining, and all of those things that go along with, a full life. I'd say that the other thing is, it should make us think about what we as a society can do that doesn't require every individual to adhere to it. And one of the things that has been supremely frustrating to me has been the fact that we can improve indoor air quality. That'll make a big difference in reducing the risk of COVID transmission. We can do it through improving HVAC systems, adding HEPA filters when you can't improve the HVAC system, having germicidal lights, UV lights. There doesn't seem to be any big drive to doing that, and I think that's a huge mistake. Not only is that anti-COVID, it's anti-flu. It also can help us in lots of other respiratory illnesses by improving the indoor air quality.
That would actually make a dent in flu, because flu still kills tens of thousands of people a year.
25 to 60,000 a year, depending on how bad the strain is. Absolutely. It'll make a difference there. So I think that's a kind of thing. We also need to change our recommendations on vaccination and how we are approaching that. No one is getting a shot every 2, 3, 4 months. No one. You can just see the huge drop off of getting booster 3 and then booster 4. Not going to happen. And so I think we need to rethink the whole vaccination approach. You need annual vaccination. We need to assess those vaccines for all of them, including the new Novavax vaccine, for durability, and really emphasize those that are durable and more broad-based.
So, Zeke, I'm hearing a couple of interesting things within the discussion, a couple of things that are new to me. So one is to say, you've got 2.5 years. That seems to be how long you could get someone to change their behavior, individual behaviors. But there's things that can be done at a systemic level to make the environment safer that aren't being done either. And those relate to, for example, ventilation. And then there's maybe a new cause for action, something people don't see so much. Maybe the long COVID might be a reason to say, hey, even if you're accepting your day-to-day risks, there's this broader risk out there. Maybe if you put 2 and 2 together and you say, look, there's these broader things that might affect me that I really don't want. Maybe I don't change my individual behavior, but I sure want the school to be well ventilated, and so on. Is there a glimmer of hope there?
Yeah, there is a glimmer of hope, but I think it means that the public health community needs to change its approach. And I do think the one place I'm most pessimistic about is, if the public moves on and politicians aren't focused on it, we actually won't fund and prioritize the things we need to do, like improving indoor air quality, which is going to take some money. We also need to develop, I would say, different therapeutics. Now, let's just make
before you go there, I think you made a really interesting point. I think you're suggesting that the shame and blame public health approach to telling people what to do, the sense that they feel condescended to, that got, I think, capitalized on by politicians who are fighting it. I do think that's part of our challenge, Zeke. And I don't know, do you have a different approach that you'd recommend? Because at this point, I think people, even whether it's a blue or a red state, are tuning out the public health authorities that they listened very carefully to 2 years ago. What approach would you recommend there?
Yeah, I think as public health people talking to the public, we need to affirm or recognize what the public is willing to tolerate, and not try to impose things that they're not willing to, they don't seem to be willing to accept. Some people, I don't know how big a proportion of the population is, will continue to wear masks. I'm one of them. Some people will continue to not dine indoors, only dine outdoors, until there's a sort of systematic improvement of air quality. But we need to recognize that's a minority. It's going to be a small minority. And so I think we need to accept that most aren't going to do that, and then ask the question, well, if most aren't going to do it, how do we change our language, and what policies should we prioritize that accepts that fact? And I do think, public health officials need to learn from their past experience and from our current experience. Look, I go to Washington. I go to whatever, the grocery store, walk down the street, go to markets, and no one's wearing a mask. I'm wearing a mask, but no one else is wearing a mask. That's where the public is. And you cannot, as they used to say, you can't fight City Hall. If the public isn't going to listen to you, whatever you say is not going to get the response we need to address the current crisis. And so we need to get the public more on board. We need to communicate. We understand where they're coming from and what they're willing and not willing to do.
Yeah, I do think that there is a fundamental communication breakdown around public health, probably in general in this country. But you look at where we have made major social movements pivot against typical behavior, whether it's Mothers Against Drunk Driving or mom's demand for gun safety. You're starting or the environmental movement, which found a way to engage people in the 60s and 70s that it seems to have failed now. There are examples where through constituency groups and changing the terms of the conversation that one was able to engage the public. And I do think it feels like there's a little bit of a failure of imagination. Is there a country or a political leader that you'd point to that's getting it right now?
I'm not sure, because honestly, the places that seem to have gotten it right, like New Zealand and others, I don't know what the current moment is. I will tell you, I have done a little traveling, not a lot, a little traveling. I was in France this summer, Israel, Jordan, and every place is in the same boat. And I think, what that made me conclude is this sort of exhaustion after 30 months of, trying to turn yourself into a pretzel to reduce your risk of COVID. That's the limit of human endurance, by and large. And it's not like, we're Americans and we're anti public health more than anyone else. I think it says something about human nature.
So John, I like where you're going in terms of like on the highway safety side. It wasn't just the kind of Mothers Against Driving Drunk, but it was also things that were happening actually with the government, and then eventually even the manufacturers. So safety didn't used to sell, and safety does sell now. And one of the reasons is you can go and see crash ratings. People actually care about safety when they buy a car, even a fast and luxurious car where that's not the only thing they're looking at. And I wonder.
Well, David,
I think that.
No, it's a great analogy, and it actually has a useful point, which is, how did we get car safety so good, right? Once we got everyone to do seatbelts. But a lot of the other stuff, airbags, I don't install the airbag. It's not even an option. It's mandated. It's just there. I'm passive, and it helps. Better crash front end crash resistance and stuff. I didn't do that. It got built in. Better highway guards, all of the stuff that got built in, so I didn't have to take an affirmative action. Really, really important. And now no one actually, the great thing is we got seatbelts to be habitual by the buzzing and all of that. No one even thinks twice about it, right? It's just like a habit. And that's really important. And we need to think through in the COVID case. I think you guys are onto it. We need to think through in the COVID case, what do we put in place, like indoor air quality, that no one has to do, or that becomes a habit. And I'll give you one of my favorites is, we need to develop a therapeutic where I spray it in my nose or mouth or whatever, and it protects me from COVID, not for a long time, but for
the dinner party, for your dance party.
Exactly, for the wedding, right? And it would become a habit. I'm going out socializing, schmutz. I just spray it in my nose and mouth. And I think that's the kind of thing we need. So if you show up at a restaurant, you show the maitre d', you sprayed it in your nose, and everyone's feeling it's easy for people to do. The other stuff is done in the background, so we don't have to take positive action. I'll tell you another thing, John and David, that would help the public with if public health officials did, that would convince them they understand. forswear closures of schools, sporting events, and other things for COVID, unless there's some really deadly strain. Because I think, that would affirm, we hear you, it's endemic, we're going to live with it, we're not going to turn, society upside down because another strain has arrived.
So Zeke, talk a little bit about the risks of long COVID and what we should be doing. I think you and I violently agree that we should be investing a lot more money in understanding it first, and then whether you see any hope. Maybe define it and then talk about how we're investing it and then how we're going to solve it, because we're actually
John,
really pretty good at solving big healthcare problems in America, as long as we acknowledge what they are.
John, you're forgetting who's the professor here. What are you telling us? Is this a three-part question? What's the story?
Long COVID, I think, is this sleeper issue. Again, human nature is such that we deal with the immediate rather than the long-term important, because we discount the future. But long COVID is, I think, one of the more scary things, because the people I know who develop long COVID are really incapacitated by it. They lack the energy. They can't do the focus. They really feel constrained. Their life has just collapsed on them, and the things that they used to do, they cannot do, and they're pretty desperate. Our problem at the moment is, first, we just haven't collected the data. It's been almost exactly 2 years. May 2020 is when we really began to identify long COVID. And the slovenly pace at which we've taken it seriously has really annoyed me. Early next month, we're supposed to get an official report from HHS on the game plan. It's a little late. But, I can't tell you how serious the risk is. Why can't I tell you? We don't have the data. Why don't we have the data? Because we didn't study it out of the box the way we should have. I can't tell you. We know that. We know vaccines reduce the risk of long COVID. How much is debated. Different studies come out with different things and numbers. It appears, and this may or may not be true, that the Omicron variant has fewer cases of long COVID, but it's hard to really know whether that's true or sampling error. And the most frustrating thing, in my opinion, is it's clearly millions of people who are suffering for that. How many millions is a little hard to tell, but millions of people. And when you talk to them, they are really desperate to do almost anything they can. And we're not doing any therapy interventions yet. Indeed, the NIH's study, as we sit here and talk, has enrolled less than 20% and maybe even less than 15% of the number of people it's supposed to enroll. And it's been, we've allocated the money for a year.
How can that be? How can that be true, given the number of people who've had COVID and now long COVID? That's insane.
I keep pounding away at that.
Well, John, first of all,
what are they doing there?
Yeah.
They have not approached this with the urgency it needs, and I think they've approached it in the usual. I'm the academic here, so I can say this in the usual academic way. They have not approached this as if this is an urgent national problem. For me, this is the urgent national problem on COVID, because if you remove long COVID, if we could say, the chance is 1 in 1,000, and by the way, here's a treatment that ameliorates it. Okay, it's like, okay, I get COVID, I'm going to be laid up for 2 weeks, but it's not the devastating,
crippling.
It's not a long-term permanent compromise of my life. On the other hand, long COVID is a long-term permanent compromise on my life, and I'm very fearful of that, especially given the rates that some people are talking about, 5%, 10%. That's a lot of people. So I think we need to turbocharge this. I've been saying this now for months and months and months. I've been screaming it at HHS for at least since January. it's kind of disappointing that we have not done a much better job. They claim they will enroll the full study by the end of the year. You know, guys, that's another 6 months. When are you going to have the first people on therapies? That should be, as your question, John, suggests, you know, we should be able to try a different therapy every week in a randomized fashion, because there are so many people who are so desperate to try anything.
Well, we are, we are not moving at warp speed, as it were. Maybe
I'm not even sure we're moving at hair speed. It's more like tortoise speed, and that's a real frustration.
So, Zeke, you asked and answered some of the questions, and or at least put them out there. You know, how many people get it? Is it more from, you know, how does this vaccine have an impact? Is one variant different from another? And you sort of answered another question, which I have, which is, how long is it? You know, I heard long COVID, longer. Is this forever, permanent? Do we know that? And how, you know, that seems to me, that's a question I have.
We don't know that for sure. Okay. Are some people permanently incapacitated the way it appears people of other post-viral syndromes are incapacitated? So I think that is something we're going to have to find out. Some people clearly recover. It's prolonged for weeks and a few months, but then they get back to normal. Other people, it's clear that it's lasted years, and they are really, really devastated.
So, John, what are you going to do about it?
Well, I think that sadly the way we get attention on things in healthcare is either through a radically aggressive constituency group, you know, ACT UP, or in my case of my family, the Cystic Fibrosis Foundation, because my sister died of cystic fibrosis, or it costs a lot of money, or there's a particular medical specialty that's politically wired. I mean, this goes down to almost power politics. It's either aggressive constituent advocacy because we were late and then very successful in AIDS, but again, and you see it in some groups that are springing cancer, or you have to have something that costs too much money to be ignored.
Well,
and I think, unfortunately, the slow burn here.
I'm a little worried about the latter, John, because if we do have millions of people who have prolonged disabilities, we will realize it costs too much, sort of too late to actually take it sufficiently seriously, and we'll be playing usual catch up. I do think this is something where, you know, it's really the research community. At the moment, this is a research problem because we don't have an intervention that we know about. And we really need a warp speed on this issue. I will be very curious to hear what the game plan is going forward. But I guess I'm not optimistic given the most recent announcement that we don't even have 5,000 people enrolled or 6,000 people enrolled in the NIH trial, which is already a small trial. It's 40,000 people as opposed to.
So should we give up on the U.S. and focus on like the NHS or the Israeli health system or the German health system, where you could,
you know, I haven't seen the Israeli health system be great on long COVID either, and I'm not 100% sure why. This does seem to be one of those things which is a worldwide failure. So.
I mean, I think it has something to do with the nature of the illness, right? If you talk about somebody that just has no energy, you know, they don't have energy to organize and to go out and march on the streets, and it's affecting adults mostly, not kids. And so you don't have just this kind of groundswell of people. The caregivers are already, if like it's somebody's spouse, you know, they don't have extra time to go out there. So I think it's also an organizing phenomenon, and there has to be political motive or profit motive or alliance with some other groups, you know, in order to make something happen. Because we can see the public health folks are not able to rise to the occasion to get everybody going.
Well, I mean, I will tell you one thing that gave me a glimmer of hope, but I don't know that it's panned out this way, is, you know, Tom Kean, senator from Virginia, has long COVID, experiencing long COVID. And usually when that happens, such a prominent, you know, former vice presidential candidate, such a prominent person, that usually galvanizes the bureaucracy to really do something. And I do think one of the worries I have is that the public's moved beyond and including long COVID. Therefore, the politicians are moving beyond COVID and losing sight of what's really urgent. And this, I mean, not urgent, really important. And this is one of those really important things. It is going to give us tremendous insight when we unravel this into the immunological system, how it goes off kilter, and things like that. And I don't think it's going to be a gold mine in terms of helping us understand autoimmune diseases and other things. We just gotta get the NIH more.
Perhaps on that happy-ish dark view, David, we should wrap this. I'll just for the first time in my life, I will be able to correct my esteemed friend Zeke that it's Tim Kaine, not Tom Kaine. Tom Kaine was the former governor of New Jersey, and Tim Kaine, I believe, is the one who's suffering from long COVID.
Right.
But on that hopeful, on the dark anecdote, David, I think we better actually wrap.
That sounds good before you start talking about Herman Cain next. In any case, that's it. That's it for yet another edition of CareTalk. We've been today with our esteemed guest, Professor Zeke Emanuel. And I'm David Williams, President of Health Business Group.
And I'm John Driscoll, the CEO of CareTalk. If you liked what you heard and you didn't, please subscribe on your favorite service. Thank you, Zeke.